صباح الخير جميعا. It's always an honor to present in front of my professors and colleagues and with my team. أنا اسمي Yara Shaheen. I'm a lecturer of Pediatric Neurology, Cairo University Children's Hospital. النهارده هنتكلم على موضوع مهم جدا بالنسبة لنا احنا كفيزيشنز وبالنسبة للبيرنتس. أنا حابة أبتدي البرزنتيشن بالparent frequently asked questions. What should I do when a seizure happens؟ يعني دي أسئلة كلنا بنتسألها سواء في عياداتنا الخاصة أو في عندنا هنا في بوريش. أسئلة دايما البيرنتس بيبقوا anxious جدا، فدايما a well-informed parent is not an anxious parent. We always try to keep them well-informed and in the picture and knowing the plan. Try to answer these questions. What should I do when a seizure happens? Should I give my child any medication during the seizure? How long should I wait before moving to the hospital? كلها أسئلة مهمة جدا وبتهدي الأهل لما يبقوا عارفين الانسرز بتاعتها. Seizures are one of the most common pediatric emergencies in general. Prompt recognition and treatment can reduce the morbidity and mortality. The incidence worldwide in 4 to 10% of children would have at least one seizure during their lifetime. والstatus incidence is 20 per 100,000 children per year. والmortality من الstatus مش رقم قليل خالص. It's 3 to 11% worldwide. شوية definitions, nomenclature مهمة to start talking about rescue medications. حاجة اسمها prolonged acute convulsive seizures، دي المرحلة اللي قبل الستاتس على طول، هي convulsive seizures lasting longer than 5 minutes. والacute repetitive seizure أو seizure cluster, it's a series of seizures occurring within a short period of time. المهم بالنسبة لنا إن نعرف إن هي distinct from the child's usual seizure pattern. في بعض الناس بتinterpret إن هي أكتر من 3 seizures in 24 hours وتبقى outside the patient's typical seizure pattern. وال ILAE doesn't explicitly list seizure cluster, but it recognizes acute repetitive seizures as a distinct clinical phenomenon. Patients اللي هم risk for these kinds of seizures, patients that have intractable epilepsy, extratemporal epilepsy, those that have symptomatic generalized epilepsy, أو patients that have previous attacks of acute repetitive seizures or a previous status epilepticus, and some selected conditions such as some DEEs such as Dravet syndrome, for example. A convulsive status epilepticus, it's a continuous or repetitive generalized tonic-clonic seizure activity with loss of consciousness for more than 30 minutes زي ما كلنا عارفين, or 2 or more discrete seizures من غير ما يرجع البيزلاين mental status. بس المهم ان احنا نبقى عارفين التايم لاين علشان early status epilepticus is from 5 to 30 minutes اللي هي impending status. Established status is longer than 30 minutes that persists after the treatment with a benzodiazepine and responded to the second line. Refractory status is a status that persists despite appropriately dosed benzodiazepine and a second line anti-seizure medication. A super refractory status, it's one that persists for more than 24 hours after initiation of anesthesia or that recurs while weaning the anesthetic. في 2 time points مهمين جدا defined by the ILAE in 2015. Time point 1 في status epilepticus, it determines when a seizure is likely to be prolonged leading to continuous seizure activity. والimplication في treatment إن هي it determines the earliest time when treatment should be considered. يعني we should consider at time point 1. Time point 2 is the time point beyond which long-term consequences are very likely to happen, including بقى neuronal injury, neuronal death, alteration of neuronal networks. Time point 2 that determines the time at which status should be controlled. مش treatment started, it should be controlled to prevent the long-term consequences. Time is brain زي ما بنقول. Status epilepticus is a dynamic condition. Will respond to drugs progressively reduced with epileptic activity progression. في early status epilepticus receptors GABA receptors are internalized وال NMDA receptors accumulate في postsynaptic membrane فبيحصل loss of inhibition و increased excitation. Benzodiazepines بيتدخلوا في هنا بقى. They act as positive allosteric modulators of the GABA receptors, but they are more likely to work if they're used early. And their efficacy decreases 20-fold over 30 minutes if used over 30 minutes. فلازم دايما نفتكر ان time is key here. The mechanism of action of benzodiazepines الempty receptor is inactive, and it's when it's coupled with chloride channel and the coupled chloride channel is closed. اول لما بيحصل binding للجابا binding of the GABA causes the chloride channel to open فيحصل hyperpolarization of the cell. البنزودايزابين بيشتغل ازاي؟ ان هو binding of the GABA is enhanced by the benzodiazepine. This results in more chloride entry to the channel, and the entry of the chloride hyperpolarizes the cell, makes it more difficult to depolarize, and therefore reducing the neuronal excitability. زي ما بنقول ان هي التايملي مانر هو ده المهم جدا ان احنا نفتكره. After the first 5 minutes we have to intervene with the first benzodiazepine. We shouldn't be later than that. الكلام كله في البيبرز دلوقتي ان after the first 5 minutes we have to give the first dose of benzodiazepines. بعد كده after 10 minutes the second dose, and then after 15 minutes we can start the second anti-seizure medication. طبعا في اول ربع ساعه ده ممكن البيشنت ما يكونش وصل اصلا المستشفى. That's why we are talking about rescue medications today. In a study in Lancet Neurology, they detected that for every minute a patient with convulsive status epilepticus is delayed in arriving to the ER, the risk of the episode lasting longer than 60 minutes increases by 5% for every minute. That's why we have to have a proper management plan, and the plan should include chronic anti-seizure medications and rescue treatments. Rescue medications, they offer an opportunity to eliminate or minimize the negative consequences, and it also provides parents, patients and caregivers a sense of control and greater confidence to safely manage acute events in a timely way. امتى نستخدمه؟ في البري-hospital setting. Different guidelines recommend administering the rescue medications ما بين 5 to 10 minutes, والكلام دلوقتي أكتر ماشي towards the less 5 minutes. In seizure clusters, in breakthrough seizures, in febrile illness-related seizures in epileptic patients, and in febrile status. وطبعا الشخص اللي بيدي rescue medication should be the care provider, often families, and it even might be useful to have rescue medications in the hospital because of the cases with difficult cannulation. So when IV access is not found, we can use the rescue medication. This is a study by Professor Vigevano et al. Where they studied the administration of rescue medication. They found it was associated significantly with seizures lasting less than 5 minutes when it's used properly. الريسكيو ميديكيشنز اللي عندنا الاوبشنز diazepam, lorazepam and midazolam, وكل واحد ليه advantages و disadvantages. Diazepam, it has a short duration of action due to the rapid distribution and accumulation with the risk, but however there's a risk of sedation. Lorazepam has a lot of adverse effects and there's a rapid development of tolerance, but it still has a rapid onset of action. Midazolam has a short duration of action, however there's a risk of seizure relapse. دول الثلاثة medications اللي بيستخدموا في rescue therapies، وفي ثلاثة rescue therapies that are currently FDA approved. The first being the diazepam rectal gel. It was approved by the FDA in 1997 for patients that are 2 years and above. Midazolam nasal spray was approved in FDA in 2019, and diazepam nasal spray in 2020 for patients aged 6 years and above. This is a very, very important paper that in epilepsy and behavior in 2021. هم عملوا acute seizure action plan, which is actually something very important for the parents and caregivers to be. They have it in schools, at home, wherever the patient spends a lot of time. So this seizure plan يعني بتوري seizure looks like normally شكلها عامل ازاي عشان لو حصل اختلاف في شكلها. What is the proper rescue treatment that should be given first, and when to call for emergency. Every patient should have this acute seizure plan, and this is actually what happens in many European countries and in the US. This is also an educational project that was done by Professor Specchio and Professor Vigevano in Italy. They had meetings in 100 primary and secondary schools, and they educated them how to manage seizures. And actually, the most important result was in 14 patients, the prolonged acute convulsive seizures were correctly managed in the classroom before even needing the ICU. This is a study that shows benzodiazepines in the management of seizures and status epilepticus. the different routes, and this is the time to cessation of the status epilepticus when using the different routes of administration. The time to cessation in IV routes are the shortest, of course, but before going to the hospital, and even if we don't have an IV access, we should consider the other modes of administration, such as rectal, buccal, and intranasal. And they all from 3 to 5 minutes. They have duration of action from 3 to 5 minutes. This is the time to application is the shortest for the 3 medications that are used in rescue therapy, and the time to cessation is the shortest for the diazepam. Some case scenarios from clinical practice. A 24-month-old boy has a cluster of febrile seizures when sick. The last 2 seizures were longer than 5 minutes. Currently, his parents are uninsured and they have concerns about the ability to provide proper care and medications. He weighs 10 kilograms. For this case, we would use rectal diazepam is the most proper choice in 5 milligrams, because usually rescue treatment is not needed for a single brief febrile seizure. If the patient has prolonged febrile seizures or repetitive febrile seizures, we have to consider having a rescue medication at home. Another case, a 6-year-old girl with Lennox-Gastaut syndrome. She has 10-minute seizure at school once per week, for which an ambulance is called every time. She's taken to the ER. Here, the proper medication would probably be an intranasal preparation, because she is at school. We will not be able to administer rectal diazepam. However, it's still a good second choice for her age and diagnosis. To manage status epilepticus, there are general considerations. We have to include that it's after the first 5 minutes, the first benzodiazepine medication should be used, whether it's rectal diazepam or buccal midazolam in phase 1 in status epilepticus. Also, the Egyptian Pediatric guideline states the same. In the first 5 minutes of status epilepticus, the first dose of benzodiazepines should be used. And this is a paper done by Professor Cross et al., and it was published in Epilepsy in 2020. She talked about the management of prolonged seizures in status epilepticus in Dravet syndrome. Here she stated that patients with Dravet syndrome need an individual care plan and detailed training using the rescue medications. And even before the 5th minute, we should use the first anti-seizure medication. According to her paper, to their paper, we should use it from 3 to 5 minutes. So here we're talking about minutes. So time is very important in rescue medication use. The first dose should be intrarectal diazepam from 3 to 5 minutes. The second dose of the diazepam from 10 to 15 minutes. And the faster we start, the better control for Dravet syndrome patients. This is the seizure clusters, the other indication, غير status epilepticus and developmental epileptic encephalopathy such as Dravet syndrome are seizure clusters like we talked about, or acute repetitive seizures is the other name. We use diazepam rectal gel for patients who are 2 years and above. The seizures clusters that were controlled after a single dose is 77% within the first 12 hours. Whereas intranasal spray, it was around 87% after the first 12 hours. And midazolam had the lowest controlled time, 61%. So the numbers of the rectal and the intranasal spray are very close to each other. Also, this is a paper in 2024 about febrile seizures and the different guidelines from different places, how to control febrile seizures. We don't usually use rescue medications in febrile seizures unless certain criteria are present, and this is according to the ILAE. They recommended the intermittent prophylaxis should be considered in cases of febrile seizures that have a high risk of recurrence, that have at least 3 episodes in 6 months or at least 4 episodes in 1 year, or complex febrile seizures that have a prolonged duration for 15 minutes or more, or require pharmacological therapy to be stopped. So the very prolonged febrile seizures, complex febrile seizures, or at least 3 episodes in 6 months, or 4 in 1 year. The intermittent prophylaxis should use rectal, the first choice, or oral diazepam. Home treatment for febrile seizures is recommended in 4 of the guidelines: the UK, the ILAE, the Indian guidelines, and the Mexican guidelines. And anti-seizure medication, rectal diazepam or intranasal midazolam, should be administered if the febrile seizure lasts more than 3 minutes, and this is according to the ILAE. 5 minutes according to the UK and Mexican guidelines, and 3 to 5 minutes to the, according to the Indian guideline. And these are the different guidelines. In the US, they use oromucosal midazolam, or the ready-to-made use bacolam, but for patients pediatric aged 3 months to 18 years. But in European, the EU, they use diazepam rectal gel for epilepsy patients weighing a minimum of 10 kilograms. But the FDA approval has approved it for 2 years and above. So the EMA approved it for 1 year, but the FDA approved it for 2 years of age and above. Rectal diazepam can be given by the syringe method, the rectal gel. However, the new medication that we have in the Egyptian market is diazicalm, and I'm very, very happy to be introducing it because we need a rescue medication, and the rescue medication will help us all, will help healthcare providers, will help parents, and will help children, and will minimize the emergency department visits. So this is the first rectal diazepam in the Egyptian market, and it's now available. بس أنا few newly introduced, yes. Newly introduced. ما احنا بالنص بقى يا دكتور بيقسموا. الحمد لله الحمد لله يا دكتور. هو موجود وفي FDA approved 97، بس انا بتكلم بعد الفتره newly introduced. ايوه yes. طيب the dose of diazepam should be 0.2 to 0.5 milligram per kg depending on the age. If 2 years to 5, 0.5 milligram per kg. 6 years through 11, 0.3 milligram per kg. 12 and older, 0.2 milligram per kg. And also we can give an additional dose of diazepam, may be given 4 to 12 hours after the first dose. But however, we should always remember that there's a treatment frequency is recommended, because rectal diazepam should be used to treat no more than 5 episodes per month. So we can't use it very frequently, or else we will have side effects. The storage, we should store the medicine in a closed container at room temperature, and if there is any remaining unused narcotic medicine, it should be taken to the drug take back location right away. It has a hydrophilic base, and this helps it dissolve quickly in rectal fluid, allowing for the fast absorption. طبعا precautions of use: hypersensitivity, glaucoma, asthma, pneumonia, or breathing disorder, or liver or kidney disease. We have to take care when using it in these patients. If we need to divide, if we need 5 milligrams, like Professor Dr. Lubna asked, we should divide the suppository بطول يعني long, يعني مش not in half. It should be divided this way, so we ensure that the cut it's cut in 2 equal proportions to be given in the same doses. My take-home message: the timely use of rescue therapy can markedly lessen the risk of developing status epilepticus. We should personalize the definition of acute repetitive seizures for each patient, because it is different for each patient. Parents and caregivers' education on use of rescue medication is highly valuable, so we should always consider giving an extra 5 or 10 minutes to explain to the parents, because this will make a big difference later on when a convulsive seizure happens or status happens. Design an acute seizure action plan, especially for the most severe cases. And this is something we don't have still. We still need to implement it. And we should have copies of that distributed all over the places where the child spends most time. Not all heroes wear capes. Some heroes carry a rescue med and a seizure action plan. Thank you very much for listening.
بصراحة سعيدة ان انا يطلع حظي في ان انا اللي هثانك يو يارا وهعرف عريف. لان انا بعتبرهم ولادي بصراحه، يعني جينيريشن جديده، ما اعرفش انتوا تعتبروها دلوقتي جديده ولا، بس بالنسبه لنا جديده. بس يعني حاجه واعده بصراحه، فحظي حلو. يعني سعيده ان انا موجوده، وعارفه ان الوقت المفروض ان انا انجز، بس مش هقدر انجز قوي علشان انا لازم بجد يعني اظهر شكري وتقديري للناس اللي كانت سبب في وجودي في جلسه زي دي. اولهم استاذي ومعلمي وابويا الروحي استاذ دكتور ابراهيم شكري، وطبعا استاذتي الفاضله الدكتوره لبنى منصور، وكنت اتمنى اكون موجوده امبارح في تكريم دكتوره عزه عرابي لانها ليها افضال عظيمه عليا. طبعا ده بجوار بقى يعني رفقاء الطريق الدكتوره مريان يسري، الدكتور عمرو غنام، استاذي اللي بتعلم منه الاخلاق الكريمه دكتور وائل السباعي. بجد كل اساتذتي انا كنت من الناس مش عارفه اقول عليه حظ ولا توفيق ربنا ان انا اكون في وسط الاساتذه والزملاء الكرام دول، فما كنتش هينفع ان انا ابتدي الجلسه من غير ما اقول الكلام ده. هنقدم دلوقتي دكتور عريف رمضان هيكلمنا عن ال challenging cases rare و reversible and often missed. اوكي اتفضل يا عم.